like to introduce Dr. Ahmed Twahir, who is a consultant nephrologist. He's fairly experienced. For the last 20 years, he's been in practice. He's got a lot of interest in hemodialysis and improvement of outcomes as far as hemodialysis is concerned. But today he's talking about prevention and delaying chronic kidney disease. We know that chronic kidney disease is quite expensive. If only we could prevent it, and if only we could delay progression to up to dialysis, up to end stage. And it's got quite an enormous task. Dr. Twahir is a consultant physician at the Aga Khan University Hospital. He also is a lecturer in medicine and runs also, is the director of the Parkland Kidney Center. Quite a resourceful man, and it's my pleasure to invite him to give his address this evening. Dr. Twahir.
Thanks, Prof. Kaima. You preempted my first slide. Thank you very much for that introduction. And my first slide is basically saying that the prevalence and severity of chronic kidney disease has been increasing for decades because of its tremendous financial and health burden, both to persons and to health systems. Mitigation of the progression of CKD is of critical importance. Diabetes is turning out to be the most important culprit in this scenario. So with that introduction, let's start. You'll all agree with me that diabetes is increasing globally and Africa has not been left behind. In fact, Africa is probably increasing more than any other continent in the world. It estimated that in the year 2030, there will be 28 million people in Africa with diabetes, and probably that will be an underestimate still. As I mentioned, diabetes is the #1 culprit in CKD end-stage causation, followed very closely by hypertension and glomerulonephritis. Now, we used to think that in Africa, glomerulonephritis was the #1, but you can see diabetes has very quickly caught up and overtaken glomerulonephritis. This was confirmed by a very simple experiment I did a few years ago, and even lately when I just walked into a dialysis room and asked how many of the patients dialyzing right now are diabetic, and indeed more than 60% of the patients in the dialysis room were diabetic. And this is not only in affluent setup, but even in Kenyatta National Hospital, you'll notice that a lot of the patients in the dialysis units are now diabetic. Unfortunately, we don't have enough resources to deal with this ever-increasing burden of kidney disease, and I want to emphasize diabetes is a major cause. If you look at the study we published early this year, showing that the number of nephrologists, although have increased from only 12 in 1995 to 26 in 2017 when we submitted this article, currently we have 44 nephrologists, but that's a very small number considering that our population is slightly over 50 million. And if you look at the number of dialysis patients have increased exponentially since the reimbursement of NHIF. In 1995, we only had 120 patients on dialysis. Now in 2017, we had 2,300, and now we actually have more than 4,500 patients on dialysis. This is in over 200 dialysis units in the country. So these slides are just to emphasize that the numbers are huge of this disease and the personnel are few. Now, how do we manage this disease? What can we do to slow it down so that it doesn't progress? We've been initially focusing a lot on glycemic control, but unfortunately, we've been barking at the wrong tree, as a Wazungu would say. We need to look at other measures. Now, when the RAS blockers came in, we were very excited because the data was very useful, but still, a lot of patients still progress to end-stage renal disease. Unfortunately, now there's a new kid in the block, the SGL2 receptor blockers, and this have shown remarkable success in terms of retarding progression. I won't focus much on that because the next speaker will focus on SGL2, but I'll mention other interventional strategies that one might use to try to slow down this dreaded disease. Very quickly, this is an oversimplification of the pathophysiology of diabetic kidney disease, but I think it will suffice for this presentation. When you have your diabetic milieu with hyperglycemia, this encourages advanced glycation end products, which leads to hemodynamic factors and growth factors and hormonal issues. And this eventually leads to glomerular hyperfiltration, altered glomerular composition, and you'll see this in the next few slides where you have basement membrane thickening, mesangial matrix expansion, renal hypertrophy, and glomerular hypertension. All this leads to albuminuria and deposition of glycated end products in the extracellular matrix, which eventually leads to glomerular sclerosis and interstitial fibrosis. Now, I'll just present a case here just to keep you in the picture to understand some of the definitions that are being used now. JM is a 55-year-old gentleman, African. He's diabetic for 15 years, hypertensive for 10 years. HbA1c is 8.5. BMI is 35. Blood pressure is 155/95. His urine albumin to creatinine ratio is 500 milligrams per gram of creatinine. The serum creatinine is 180, translating to a GFR of about 41 to 44, depending on whether it's EPI or MDRD. So this is a typical type of patient who will come to any of you in the clinic. And in terms of definition, CKD grading, he's in G3B, with which translates into moderately to severely decreased GFR. His GFR is between 30 to 44. In terms of his albuminuria, and what is now politically correct is to use severely increased rather than macroalbuminuria, and the term microalbuminuria has been changed to moderately increased. So this patient is in severely increased albuminuria, and if you look at this table, he actually falls under very high risk of progressing to end-stage renal disease. So earlier on, when our patients have microalbuminuria, I just want to let you know this is not a benign condition because it's associated with increased incidences of coronary heart disease, stroke, and other diseases. So let's not underestimate the importance of microalbuminuria. And it's easy to understand because once you start leaking protein in the urine, it's an indication of endothelial dysfunction. And you know the endothelium is spread throughout the body, including the brain and the heart. So as proteinuria advances, you'll find that it's associated with increased events, both coronary heart disease and stroke. And patients who are diabetic with end-stage renal disease are at particularly high risk of cardiovascular complications, including concentric left ventricular hypertrophy, ischemic heart disease, and cardiac failure. And mortality among hemodialysis patients are higher if you are diabetic than if you are non-diabetic. And also mortality is more frequent in type 2 diabetics with kidney disease than those without, as you can see from this table. Diabetes, no kidney disease, standardized 10-year cumulative incidence of mortality is 4.1. Once you start getting albuminuria, it increases to 17.8. Once the CKD sets in, increases to 23.9. Once you have both, mortality increases to 47%. And if you have neither, then you don't have diabetes, you don't have any kidney disease, then you're at 7.7%. So this slide is just to emphasize that having CKD, albuminuria, and diabetes is not a very good combination. This is a slide from my friend Carl Eric Morgensen from Steno, just to try to map out the natural history of diabetic nephropathy. He was the first guy really, and what he did, he looked at patients with type 1 diabetes, and he chose type 1s because it was easier to identify the onset of diabetes in these patients. And he followed them up over a period of years, and he came up with this with this graphs showing that the GFR initially goes up. You get the hyperfiltration in stage 1, and then in stage 2 you get the structural changes. In stage 3 you get what is called the mildly elevated albumin. In the past we used to call it microalbuminuria. In stage 4 you get overt nephropathy until stage 5. Now if you look at this slide, it tells you that from onset of type 1 to end stage, it takes 30 years. And many people agree that type 2 diabetes tends to follow the same pattern once you map out the onset of diabetes. So 30 years is a long time for Africans indeed, because if you look at our patient population, and all of you who have managed diabetic patients with kidney disease, you'll agree with me that once you start seeing protein in the urine, these people don't have long to go. Either they'll die of a cardiovascular complication, or they'll quickly go into end-stage renal disease. So unlike the Caucasian population, our African population are at higher risk. They progress faster. And I like calling this the African kidney because we have double pathology. We are exposed to tropical diseases. Those of you who attended Dr. Ware's talk on tropical nephropathies will understand what I'm saying. And we're also exposed to this non-communicable disease, the dreaded diabetes. So we have a double pathology, and probably this might explain why our African patients progress much faster than the Caucasian counterpart. This is my friend Carl Eric Morgensen. So I wasn't lying when I was showing you this study, saying that actually he's my friend. This is a picture that I took with him when I was in, this was in Durban in South Africa during one of the diabetes meetings. Okay, so this is a slide, or this classification, I like it because it actually not only focuses on the glomerular lesions of diabetes, which it also touches on the interstitial lesions. Many classifications in the past left out the interstitial lesions and just focused on the glomerular pathology. But what we learn more and more is, apart from the typical glomerular sclerosis, giving you the Kimmel-Still-Wilson lesion, which we've all learned about, we get a lot of parenchymal damage, interstitial fibrosis, and tubular atrophy, which characterizes a lot of our type 2 diabetic patients. And indeed, if you look at renal biopsies of type 1s patients, they will express more of the glomerular lesions, whereas type 2 patients will express more of the parenchymal interstitial fibrosis, tubular atrophy. And that is why we've recently discovered entities of what we call now non-proteinuric diabetic kidney disease. In the past, we used to think that all diabetic kidney disease will have proteinuria, and hence the term diabetic nephropathy. Since we learned that many patients might not get proteinuria, in fact, the term diabetic nephropathy has now become obsolete. And what is more politically correct is diabetic kidney disease, or even better, diabetes with chronic kidney disease, because we realize that not all diabetic patients with chronic kidney disease have diabetes as their renal pathology. It might actually be non-diabetic. So the more politically correct term is diabetic with chronic kidney disease. This is the same thing in focusing on the other lesions outside the glomerular. And that's why I said I like this classification that was proposed by Tarvat in the Journal of American Society of Nephrology in 2010. Those of you who like looking at renal pathology specimens, and I know most of the nephrologists like doing that because they don't trust anybody else except themselves. There are many nephrologists, after doing a biopsy, will actually go to the histology lab and request the histopathologist, can I please look at the specimen with you? And you'll actually find in the diabetic, you start with mesangial expansion with basement membrane thickening, and then the nodular glomerulosclerosis, which I touched on earlier. And this is the same thing, nodular glomerulosclerosis. Okay, let's come to the interventional studies that have been done to show that there's benefit. And I said, since the RAS blockers came, there's been like a major shift and an excitement in terms of reducing the progression of kidney disease. And this is a slide looking at telmisartan in patients with, I'll use the term microalbuminuria because I'm more used to it, although I know it's not politically correct. So these are patients with microalbuminuria who are exposed either to placebo, telmisartan 40 or telmisartan 80. And indeed, it showed that patients who were on telmisartan 80 were less likely to progress to overt nephropathy. And indeed, the patients who are on telmisartan 80, many of them actually shifted from their microalbuminuria to normal albuminuria. And the conclusion of this innovation study said that in patients with type 2 diabetes and microalbuminuria, telmisartan 40 or 80 provides superior renal protection, and microalbuminuria remission was also superior with both telmisartan 40 and 80. So this is very early in the course of your diabetic kidney disease when you get this microalbuminuria, and this is a good time to intervene with your RAS blockade. This is a similar study, but this was looking at irbesartan. Irbesartan is also an angiotensin 2 receptor blocker, and they exposed these patients to placebo, 150 milligrams and 300 milligrams, and they found the same pattern as we did in the innovation study, that there was regression of the microalbuminuria and less progression the higher you go. So the message here is you need to titrate until you reach maximum tolerated doses or recommended doses by the company. This is the IDNT. IDNT stands for irbesartan in diabetic nephropathy trial. And it was looking at patients now with macroalbuminuria or frank proteinuria, or more politically correct, markedly increased albumin excretion. And it was looking at whether we could reduce the doubling of the serum creatinine in end-stage renal disease or death. And these are hard endpoints. So you could argue that whatever I mentioned earlier, those were soft endpoints. You're not very convinced. You don't like soft surrogate markers, but this is hard. Look at what this did. You are able to statistically significant improvement of doubling of the serum creatinine, end-stage renal disease and death. And this is a renal study by Barry Brenner, where he did the same thing with losartan, patients with proteinuria, where you had 1 dipsticks protein of urine. I've said in our environment, these patients progress very fast to end-stage renal disease, or they die even before they reach dialysis. So let's not underestimate. We have a momentarium to intervene. So I've shown you on the previous slide was irbesartan, and this is losartan. There are several studies that have been published looking at intervention of RAS blockade. I just listed them down here because of the interest of time. And what I want to mention in this slide is that many people have asked the question, if 1 RAS blockade is better, don't you think that 2 would be better? So indeed, a very interesting question, but several studies were done combining both ACE inhibitors and A2 receptor blockers, or A2 receptor blockers and direct renin inhibitors, and they found that double RAS blockade, although might reduce proteinuria, was associated with more hyperkalemia, worsening renal function. So following these studies, we completely avoid double RAS blockade in our patients. So more is not better. That's the message. Or two is not better than one. Now, when we're using RAS blockers, one of the issues that we need to appreciate is that RAS blockers are double-edged swords. They are very good at retarding progression, but one of their major drawbacks is hyperkalemia. They can elevate your creatinine and cause acute kidney injury, especially if you're dehydrated or you're using other nephrotoxic drugs. And the teaching here is that when your potassium reaches 5.5, think twice about your RAS blocker, and I'll show you measures of what you can do to mitigate the hyperkalemia. If your serum creatinine rises up by more than 25 to 30%, you need to also be careful because you're probably treading into dangerous waters now. I'll mention some of the issues in terms of how do you deal with hyperkalemia? Either cut down your drug by 50% or stop completely. And the other ways is to bind the potassium and also advise them on low potassium diet. You might consider diuretics because one of the side effects is hypokalemia or sodium bicarbonate. I'll show you data showing the benefits of sodium bicarbonate in CKD. Now, you'll see from that slide, there's some two new drugs that have been introduced in the market. One is fatiroma and the other one is zirconium. And these drugs are potassium binders. The argument was that kayexalate had a lot of side effects, and I don't agree very much so because I've used kayexalate for many years as a potassium binder, and I've never seen any of the side effects reported like intestinal necrosis. Although it's reported that when you use sorbitol in combination with kayexalate, you tend to get more of this side effect profile. So I've never used it with sorbitol, and maybe that's why I've never got this side effect. The only other explanation I can have, Resonium is a very cheap drug. It's been in the market for long. The other pharmaceutical companies are trying to push it out of the market. So you'll see a lot of bad things about it. But anyway, there are newer drugs coming up with better probably safety profile. So question is, many people ask me, when should we stop the RAS blockers? Is there a time in the progression of kidney disease that they're actually detrimental rather than beneficial? So what I tell them is anybody with a GFR of more than 30, you have no choice. There's no reason not to put them on a RAS blocker. Anybody with a GFR of less than 20, I'd probably try to avoid RAS blockers because of the effect that they can worsen your renal functions. And between 20 and 30, I'd say I don't know until the results of the Stop ACE study come out. And this is a multinational, multi-center study randomizing the use of RAS blockade in advanced renal disease. So when this come out, probably we'll be able to answer that question better. An interesting drug, very cheap, all of you will be familiar with it, spironolactone, aldactone. We learned that in the RAIL study that it was useful in congestive cardiac failure, then came its follow up the eplerenone, showing also that this mineralocorticoid antagonists were useful in heart failure because of their antifibrotic effect. Now, the question that was asked, are they also useful in diabetic kidney disease? And if you look, yes, in terms of reducing albumin excretion, these are soft endpoints. You could argue this is not like the doubling of the serum creatinine that would like, but still, there is some benefit in reducing albumin excretion using mineralocorticoid antagonist. And one of the challenges of spironolactone is hyperkalemia. So following that, obviously people are quite smart. Whenever there's a challenge, they come up with new drugs. So there's one new kid on the block is finerenone. Finerenone is a more advanced mineralocorticoid antagonist. It is more receptor specific and it is associated with less hyperkalemia. And there are two studies that are ongoing, Figaro and Fidelio. And as I was presenting this when I was researching this presentation, I actually realized that the Fidelio data is out, and I wanted to share it with you. So it came out on October 23rd, just a week ago, and it was published in the New England Journal of Medicine by George Bakris. The effect of finerenone on chronic kidney disease outcomes, and it concluded that in patients with CKD and type 2 diabetes, treatment with finerenone resulted in lower risk of CKD progression and cardiovascular events than placebo. And this slide shows the placebo and finerenone in terms of urine albumin excretion. And also this is the potassium. The finerenone is equal to placebo. So this is amazing. If this is true, then we can comfortably use a drug that will not give us hyperkalemia, but it will be involved in progression, the improvement or progression of renal disease. And this is looking at the different endpoints. You'll see that overall, I won't go through all these different parameters, but overall, finerenone was better than placebo in most of these many variables. So again, we look forward to this drug into the market. So what are the blood pressure targets we need to aim for to be able to help our diabetic patients with kidney disease slow down their progression? And this was very well summarized in the KDIGO blood pressure management in CKD. So that's made my life easier. So I'll just present a summary in a table form. So that whole booklet concluded that if your patient had a urine albumin excretion of less than 30, which is basically normal, then target a blood pressure of 140/90. And if you look at the European Society of Cardiology, they said 140/85. And in terms of antihypertensive agents, it didn't really matter. You didn't have to use a RAS blocker. Although I would recommend that because many of our patients will slowly creep into elevated albumin, I would be more comfortable in using a RAS blocker than any antihypertensive at this level of treatment. However, if the patient had elevated albumin excretion, both micro or macro, and whether they were diabetic or not, the recommendation was you target 130/80 or less, and preferable to use a RAS blocker. Now comes a new kid on the block. I won't touch on this much because Dr. Berger is an expert on the SGL2 receptor blockers, and the next topic is his. But very quickly, these are studies looking specifically at renal outcomes, the EMPA-REG, the CREDENCE, the DAPA-CKD. Now, why I brought this study on DAPA-CKD is to show you that in this study, they included patients with GFR between 25 and 75. Now, what's exciting is when these drugs came out, they said they should be not used in patients with GFR of less than 45. So that was a little bit disappointing because we thought we would lose out on our patients because these drugs are amazing. Not only do they reduce progression of CKD, they also improve patients with heart failure. They are also useful in patients with hyperuricemia. They're also beneficial in patients with fatty liver. And I was excited when I heard that you can actually use them up to a GFR of 25. And who knows, maybe other studies might come out that you could actually use them even lower. We're yet to see. Now the data is quite exciting because in the EMPA-REG outcome, it showed clearly that progression to macroalbuminuria reduced by 38%, doubling of the serum creatinine 44%, and initiation of renal replacement therapy 55%. Now, apart from the proteinuria, these are hard endpoints, the doubling of the serum creatinine and initiation of dialysis. So again, I look at these numbers and I really get excited when I see them. Again, the EMPEROR-reduced study, although this was mainly in patients with heart failure, they looked at patients' renal outcomes also, and they found that there was a significant improvement. Although this was a secondary outcome, I still got excited knowing that patients on empagliflozin actually had a mean change in GFR per year of negative 0.55, which was much lower than if you are not on empagliflozin. Your GFR tended to decline much faster than if you are on empagliflozin. Okay, so what about other drugs? Liraglutide is a GLP-1 analog that is mainly given that is given as an injectable, and it's supposed to improve glycemic control. And what did it tell us? It said that patients given liraglutide had an improvement on their albumin excretion rate. Now, this is a soft endpoint, so unfortunately, I'm not too excited about the liraglutide data because it didn't really give me any hard evidence. And they concluded that liraglutide significantly reduced renal outcomes. But remember, listen to the whole sentence. In patients with type 2 diabetes and high risk of cardiovascular disease, largely driven by a lower incidence of macroalbuminuria. So soft endpoint, what excites me more now is doubling of the serum creatinine, end-stage renal disease and mortalities. It didn't have that benefit. So unfortunately, liraglutide is not a favorite for me. So in terms of other drugs, looking at glycemic control, you all remember the DCCT and its follow-up, the EDIC study, the UK-PDS in type 2s, the CORD, ADVANCE, and the VADT study. Now I'm putting these studies mainly to emphasize that unfortunately glycemic control has not proved very useful in retarding renal disease in patients with advanced renal failure. The only time you'll see it's beneficial is in patients with very early diabetes involvement. By the time the patient starts going into CKD stage 3 and 4, unfortunately, there's not much data to show improvement in glycemic control. And even the SGL2 receptor blockers, the benefit that they create in these studies is not because of their glycemic control, it's because of other mechanisms other than their glycemic control, which I'm sure Dr. Berger will touch on. Now, are there other therapies? We've talked of RAS blockers, we've talked of SGL2 receptor blockers, and we've talked of mineralocorticoid antagonists. Now, there's sodium bicarbonate. Sodium bicarbonate is what our wives and mothers used in making cakes. This is baking powder. Now, my friend Yakub from UK was involved in this study, and they randomized patients to sodium bicarbonate tablets versus placebo. And indeed, they found a beneficial effect of using sodium bicarbonate in patients who had a low bicarbonate of less than 20. And indeed, the KDIGO published in 2012 Clinical Practice Guidelines for Evaluation and Management of CKD. And this is what they mentioned, and this was level 2B evidence. We suggest that in people with CKD and serum bicarbonate concentration below 22, treatment with oral bicarbonate supplementation be given to maintain serum bicarbonate within normal range and less contraindicated. Now, the good thing is that sodium bicarbonate tablets are very cheap. A 300 milligram tablet costs 50 cents. The dose is 600 milligrams TDS up to 1 gram TDS. So this is cheap. Nobody markets this because there's no profit gains in this, but you must be aware is you can use this, it's cheap, and it helps. So the question that also I get asked is, what about uric acid? Can you tell us whether uric acid is detrimental to the kidney and whether reducing uric acid has beneficial effects? Now, again, the KDIGO, same publication in 2012, and this is what it said. There is insufficient evidence to support or refute the use of agents to lower serum uric acid concentrations in people with CKD and either symptomatic or asymptomatic hyperuricemia in order to delay progression of CKD. So when I saw this statement, I was very disappointed, and I went and did a lot of literature search to see whether I could actually find evidence to support this. And I first decided to understand the mechanisms which uric acid may cause renal damage. So the possible mechanisms is that uric acid has been associated with RAS activation, increased oxidative stress, mitochondrial dysfunction, endothelial dysfunction, vascular smooth muscle proliferation. And this leads to, in terms from the kidney side, arteriosclerosis, glomerular hypertension, glomerular sclerosis, interstitial disease, and even acute kidney injury. So if you look at the pathophysiology, uric acid clearly has a role to play in causing renal damage, but does lowering uric acid help? So again, I did a lot of research and I found an article in MDT 2014 looking at effects of uric acid lowering therapy on renal outcomes. And it concluded and said that uric acid lowering therapy with allopurinol may retard the progression of CKD. Again, it added, however, adequately powered randomized trials are required to evaluate the benefits and risk of uric acid lowering therapy. So I did another search. This was a more recent 2018, and it was titled Effects of Uric Acid Lowering Therapy on the Progression of Chronic Kidney Disease. And this was actually a meta-analysis. And it concluded and said uric acid lowering therapy may be effective in retarding the progression of CKD. And again, added further randomized controlled trials should be performed. Again, this year in June 25th, New England Journal came up with effects of allopurinol on the progression of kidney disease. And this was a CKD fixed study. When I read this, my heart broke down because I was really looking forward to intervening by lowering uric acid. So the conclusion of this study said, in patients with chronic kidney disease and a high risk of progression, uric acid lowering treatment with allopurinol did not slow the decline in GFR as compared with placebo. So, and if you look at, although the albuminuria rate was much decreased using the allopurinol, the creatinine did not change much, the GFR did not change really. It was, compared to placebo, there was no difference. So as I said, I was heartbroken and I decided to read the editorial comments to see whether I can disprove this study. So the comment said, however, this study did not address urate lowering therapy, either pharmacological or dietary, in younger patients or in those with earlier stages of kidney disease. So I got some hope and I said, maybe I still have a chance if I intervene earlier. And then another comment raised by somebody said, the CKD fix was limited by inadequate power, the inclusion of participants with normal serum uric acid, no targeting of therapeutic levels of uric acid, and a high percentage of participants who discontinued the trial, and this reached actually up to 30%. So again, a recent meta-analysis observational studies involving patients with gout concluded that allopurinol initiation was not associated with an increased risk of death as compared with no use. This was recently in April 2020. And so when I read this, I got excited and I said, maybe there's still some hope for me using uric lowering acid therapy, until I came across this study in the New England Journal of Medicine, the CARES study, saying that febuxostat, which is a uric acid lowering therapy, was associated with major cardiovascular events that were similar to those associated with allopurinol. And the cardiovascular events and death rates were more frequent with febuxostat than with allopurinol. So again, I've been heartbroken again because I'm lost as to what interventional agent I can use. And I'm hoping that somebody comes up with a newer agent, hopefully rasburicase. I've not seen any data on rasburicase in retarding progression of renal disease, but that would be an exciting drug. Hopefully it might not be associated with all these complications. That's the end of my slide. I just want to let you know that after this conference, I'm taking a flight to Lamu, which is the town I love most in this country. I'm going to there for a holiday, and I'll be thinking about you guys when I'm by the beach. Thank you very much.